I teraz, drodzy Państwo, zapraszamy na dwa wydarzenia online. Pierwszy wykład jest to wykład pana profesora Rory'ego Conna, który dotyczy prowadzenia trudnych rozmów na temat dystrofii mięśniowej Duchenne'a, czyli jak, gdzie i kiedy rozpocząć i prowadzić rozmowy o chorobie, jej przyczynach i skutkach w gronie rodziny, z pacjentami oraz między specjalistami. Witamy, panie profesorze, a Państwa zapraszam do wysłuchania wykładu.
Thank you very much. I'm just going to make sure that I can share my slides with you. And I wish I could be with you in person, but it was not possible for me to fly over on this occasion. Can I check that you can hear me okay?
Yes, we can hear you.
Good. And can you see my slides?
Not yet.
Okay. It says that I'm sharing my screen at the minute.
Just a few seconds, because I must withdraw our screenshot.
Okay.
I don't know what to do. I'm sorry, but we have to wait for somebody from technical.
Okay. Well, I can start talking, and then hopefully in a couple of minutes we will be able to have my slides. I would love to speak to you in Polish, but that's not my skill. I'm calling in from the UK. I live in the southwest of England, in a place called Exeter, where probably none of you have been before. And I want to begin by talking a little bit about the project that I'm involved with and what I do. So I'm a consultant child and adolescent psychiatrist. And the sort of psychiatry that I do is called liaison psychiatry. And liaison psychiatry is where the body and the mind come together. And so I work very closely with pediatricians. I can see my slides are sharing. That's fantastic. Thank you. I work very closely with pediatricians, and I'm very interested in physical health conditions that can cause psychological and psychiatric problems, both because of the psychological impacts that they have, for example, depression and anxiety, but also because of the direct brain effects. And when Duchenne UK, the organization, approached me and asked, would I be interested in helping with a 3-year project on Duchenne, I was very excited about this. I didn't really know much about Duchenne at all, is the truth, but the invitation was to help the team to understand better the psychological, psychiatric problems with Duchenne and to improve the standards of care across the UK. And it's a 3-year project that I just work on my Fridays. So it's great your conference happened to be on a Friday. And the rest of the time I work in child and adolescent mental health generally. I have a website, Connected Child Health, where I write a lot about the body and the mind. And I'm also on Twitter or X, if you follow that sort of thing. So I'll try moving my slides forward. Yes, great, I can see that's working. So in the UK, it was recognized that whilst there had been major improvements in the standards of care for children with Duchenne from the point of view of cardiac health, respiratory health, physiotherapy, and so on, it was recognized that there was a significant area of difficulty. And there is a network called the North Star Network, which was set up more than 20 years ago, where there were sites around the country, in fact 24 of them listed here, and you can see these little pink pins are spread out across the UK. And the North Star sites are hubs of excellence in which patients with Duchenne muscular dystrophy can travel to get a coherent and collaborative good standard of care. And I'm sure you must have similar things in Poland, but forgive me, I don't know how it would work with you. So I actually live just in the bottom left-hand corner. There's a blurred bit that says Exeter, but the nearest hub to me is Bristol, which is just up slightly from there. So the background to the project, I'm sure you'll be familiar with the Lancet publication from 2018, setting the international standards of care. We all refer to those. But because it was recognized these weren't being delivered adequately in the UK, and that there were discrepancies between the sites, there were individual differences between the standard of care, and indeed how long people with Duchenne as a result were living in different areas, the North Star Network was set up. And then Newcastle University funded a project in 2020 looking at these standards of care and how they could be delivered. And there was a survey of patients and families conducted by DMD Care UK. This is the percentage of respondents who are dissatisfied, unhappy with the standard of care in different areas. And you can see there is a big spike here. More than 45% of carers said that the psychosocial care that they were receiving was poor, compared to, for example, 5% of respiratory. So it was recognized there needed to be a lot of work here. And specifically, I was interested in looking at the outcomes within that data relevant to my work. And it was found that discussions about mental health were only reported by 8% of patients and 5% of their families, their carers. And additionally, that screening tools, so questionnaires looking for mental health problems, were almost never used for this group of young people, which is a real problem and a real deficit in care. And I understand from Darius that in the audience today, there's about 50% of carers, I think, and parents, about 20% of doctors and 20% of teachers. So I'm going to try and make this talk applicable to everyone. So I'm going to show, this is a screenshot of the North Star assessment, and there's a tick box exercise, we would call this in England, and I've highlighted the area, behavioural changes, and the doctor will tick or cross none, mild, moderate, or severe. And that doesn't really mean very much, really, unless we define what those things are. And that's because these are quite complex and difficult things to explore, and that's what my talk is going to be about today. The next slide here is the team that I work with. That's me on the left, and then we have a pediatric psychologist just next to me, and a clinical psychologist who sees adults in London, and there is an adult neuropsychiatrist that I work with as well. And what we're trying to do is develop consensus guidelines on the psychosocial management of boys with and men with DMD. And I've also received additional funding for my role from the Joining Jack charity. So the aims were to improve the knowledge and confidence and capabilities of clinicians working in the North Star sites, to help them develop and use screening tools which could identify mental health problems, and to make sure that timely access was given to therapy and potentially medication for mental health difficulties in order to reduce the mental health problems overall. I am familiar with difficult conversations about genetic disorders. When I was at medical school, we were encouraged not to, when we were sitting in lectures, to hear about conditions and self-diagnose. And it was always a running joke that you, a medical student, would be very paranoid about their health. But I sat in a lecture in my 4th year about a bone condition called osteogenesis imperfecta, brittle bones disease, where people have a high number of fractures and blue sclerae, the whites of the eyes being blue, and hypermobility as well, joints that bend too far. And I recognized that this was something that I maybe had, and I self-diagnosed this problem. And I was right, I had genetic testing, and I do suffer quite a large number of fractures, but it wasn't picked up until I self-diagnosed age 23 or something. But I've had genetic counseling. I've had 2 children who have both inherited this condition from me. There was a 50% chance that any child would, and they've inherited from me. And so I've had bisphosphonate treatments with zoledronate, and so has my son, who has slightly more severe form than my daughter. And I tell you this because I am familiar with parenting a child with a chronic condition. I'm familiar with the anxiety that it can produce. I can tell you there's been years of running around after my kids, making sure they don't fall over. And I'm familiar with talking to my children about a complex subject so that they can understand it. And I just wanted to share that because sometimes professionals can speak from a position which is very authoritative, but not necessarily through lived experience. So here's a brief case study I want to tell you about. An 11-year-old child referred to me as part of the project with sudden onset difficulty with sleeping, was very tearful and becoming very dysregulated and angry and refusing to go to school. And the question was, had this 11-year-old developed a mental health problem? And we've heard earlier about the risks of Dr. Google. What had happened as I explored it was that this child had gone onto Google and found out about Duchenne and read a number of frightening stories and seen lots of photos of impairment. And it turns out he'd never had any real conversation about Duchenne. It had been avoided. And he didn't know why he was struggling to keep up and needing lots of appointments and physiotherapy and so on. So what had gone on here was an avoidance of difficult conversations. And I can tell you, I understand, and all of us will understand why we do these avoidances and why that seems important. In another family I was talking to, they said to me online, oh, we don't talk about the D word, in inverted commas. And I thought they were referring to death, but they were referring to Duchenne. And this was a child about the age of 8. And the parents said, no, we don't talk about it even with the clinicians. And the problem with that is it's about secrecy. And from our first excellent talk, we heard about the importance of patient-centered inclusive care being based on trust. And the idea that children don't hear or understand what is going on around them is problematic. There are lots of resources out there, actually, and I'm talking, I suppose, mostly to the carers in the room. And David Schoenfeld, I've heard talk before, he's absolutely fantastic about how to have these difficult conversations with children. And there are resources out there. So if there is a parent or carer in the room who's wondering how and when to do this, I'd encourage you to look up some good resources and do it as soon as possible. One of the issues is that both as clinicians, doctors, and families, we might think, well, they don't really seem to understand these things, they're too complicated. But we know that there are speech and language problems in Duchenne that can affect the production of speech, so expressive language problems, and also receptive problems. And Sam, who is talking later, I've quoted here from him, difficulties in verbal communication, relying on parents to express their experiences for them. But that's problematic as children move to older ages, and we can't be reliant on parents always knowing how their children are feeling, actually. And it shouldn't be the duty of the parent to be understanding and reporting on that. So what I really liked earlier in the first talk was that emphasis around a move away from formal to simple language and using short words with few syllables and slowing things down. And I notice actually, although I tend to talk quite quickly, I'm slowing things down today a little bit because of the audience and the language barrier that we have between us. Also important is the use of what our first speaker, Matthias, talked about, diverse stimuli, and these being good. So I'm showing you here a fantastic resource, the Mission Duchenne comics, which are freely downloadable online, which give graphic representation for a child living with Duchenne about their difficulties that they're probably having. But they make them animated and visual, and that will help boys to understand what is going on in their bodies. If people don't have an idea of what is going on in their bodies, they will be confused about it. There's also a very good animation on YouTube that you could look at. I find that if I'm involved in these conversations, using simple visual tools is really important. And this is an example of showing how in a long genetic sequence, if you lose a single piece, things don't make enough sense. They do make some sense, perhaps, but in terms of genetic variance, here on the screen is a way in which a geneticist might explain to a young child why their genes aren't being quite read properly, which is a nice way of saying it. I'm very wary of metaphors. I heard about metaphors in the first speech, but because boys with Duchenne tend to be very literal and concrete in their understanding, we have to be cautious. I quite like to use an extended metaphor about what goes on in the brain, with this smoke alarm being the amygdala of the brain. The amygdala is the center of our brain that does fight, flight, and freeze. It is sort of the source of anxiety. And we know that with a lack of dystrophin, the amygdala doesn't work as strongly as it should. And I won't explain this extended metaphor, but for some young people, it's really helpful to say, look, the smoke detector in your brain is overly sensitive, and that's why you're getting this drive to feel very anxious all the time. But as I say, beware of metaphors, because that child might leave the room thinking that they have a smoke device in their brain, or that smoke is dangerous for them, or whatever. So you have to check, do they have a good understanding of things like metaphors? So information needs to be, this is key to remember, I think. And I just came up with as many A's as I could because I thought it would then be memorable. Information needs to be available, so not secretive, not hidden away. It needs to be accurate, so not just what we find on Google, which we know can be out of date, or it can be wrong. It needs to be accessible, so not only available in a library, but available in the clinic setting. The handouts that a young person might be given and proactively offered to look at. And it needs to be age appropriate, of course. So the information that we give to a 6-year-old about Duchenne is going to be very different from the information we give to a 16-year-old or a 26-year-old about Duchenne, probably. Here is another very good visual example about X-linked conditions. And it can help to explain, for example, to a family why a carrier mum might have some of the difficulties seen in Duchenne as well, some of the perhaps processing difficulties, which can be very subtle and not picked up. And in the national guidelines that we are writing, which are still in draft form at the minute, I thought I wanted to come up with another way we could put in a box of explaining this. And I think when young people come to their appointments in the North Star centres, we need to be following this quite strictly. We need to be asking ourselves, we need to be asking the parents or carers and the young people themselves, what do they need to know at this point? That is necessity. What is the child able to understand? We call that their capacity. What does the child want to know? Their desire. They might say, no, I don't want to talk about this at all. That's fine. And what are the parents or carers willing to discuss? Because again, there may be families who say, this is not an area we want to explore, hopefully at this time, because as I'm saying in this talk, there are problems with being secretive, even if we're seeking to protect people. And I can tell you now from experience that these are some of the things that boys with Duchenne that I've met might think if they have inadequate information. I'm naughty. there's something wrong with me. My muscles are bad. I'm hopeless at everything. I'm stupid. I can't learn, etc. And families also and professionals might fall into pitfalls. I don't know how that would translate in English expression, things we can fall into of thinking, well, we can't do anything about this because it's part of Duchenne. Rather than thinking, for example, well, this feels quite a lot like ADHD and there might be a treatment available for this. So when do you have the conversation with children? This is from a pediatrician I work with closely down in Exeter who sees boys with Duchenne. And he wrote this to me in an email right at the start of the project. And it was so good that I thought I would copy it and paste it here. So best done when the child has gradually taken in this significance, perhaps at a slightly older age. And then there are healthy tears and reflections with the family. But worse done when information is dumped on a child, or if parents or the professionals avoid doing it, avoiding having any conversation. Having said that, Richard says, I don't think we have the right to remove the wish to not talk about it, if that is the agreed position. There are other difficult sorts of conversations that I want to touch on. And there are people in this conference who know much more about this than me. But I've been struck throughout the project about the difficulty of knowing whether autism, ASC, and ADHD in Duchenne muscular dystrophy is the same or different to when we see those conditions in people who have sufficient dystrophin. So are we actually describing attentional problems because of a lack of dystrophin? Should we conceptualize this as ADHD as we do in the same way? But actually, I've come to learn as a child psychiatrist anyway that ADHD is not a single thing. Otherwise, there would be a test for it, like there is with Duchenne. ADHD is a collection of symptoms, and it is a fallacy to think that ADHD is one problem. As a result, I'm actually quite keen on the idea, if there is evidence of impairment in focus and concentration, and also sometimes hyperactivity, that we should use empirical trials of stimulant medication, assuming it is safe to do so with the cardiac effects, to see if children with Duchenne respond and improve to the main medicine, which is methylphenidate. And I don't think we necessarily need to have a firm diagnosis of ADHD to do that. I want to use another metaphor, which I think is very helpful, and tell you about this because I use this all the time in CAMS. Don't try and read the writing here. But this is a metaphor that imagines we are all a bit like a tin, a biscuit tin, and the coloured balls represent areas of difficulty. And if there are enough coloured balls in a stack to go over a line that we've decided, then a diagnosis might be made. This is how mental health works, really. And that's all okay if the child or the patient is like the bottom left hand, when there is one significant problem that goes above a line. But many of the patients I see in my clinical work, and especially boys with Duchenne, tend to have the right-hand corner where there are lots of areas of weaknesses and strength, but maybe none of them quite go over a given line. So maybe they don't get a diagnosis of autism or ADHD or specific learning difficulties. And I like to talk with families about the spiky profile of Duchenne muscular dystrophy. And what this recognizes, if we do cognitive testing, is it shows that many boys with Duchenne have real areas of strength, like their fact-based memory, their vocabulary can be very good, their spatial awareness, but we all know the common areas of weakness. But it's important to have conversations with young people with Duchenne that say, look, you've got some stuff you are brilliant at. You are fantastic at this, but also we know that you need extra support with these things. So focusing on the strengths is massively important. And I wanted to put that as a slide in its own right. I devised a very straightforward questionnaire that I'm trying to get young people to fill out when they come to clinic. And I do this because it's easier for lots of boys with Duchenne to have time to think and to write, to communicate, rather than be put on the spot and say, tell me how you're feeling. Because most boys with Duchenne will say, I'm fine, or I don't know, because they cannot process that and they might not be able to communicate through language as easily as others. So I invite them to tell us what's going on well, what's going well in life at the minute. What are you proud of? What are you looking forward to? And then are there any questions that when you come into this appointment, you would like to ask about your condition? Are there any things you felt unable to ask when you've come before? And is there anything that's worrying you or the people looking after you? So these are very important psychosocial questions. And unless we give time to them, and unless we give children and adults the opportunity to write them down, then the whole appointment will be full with questions about respiratory, cardiac problems, etc. And those are not really things that the boys are worried so much about, in my view. Finally, I think there's 2 or 3 more slides. Systemic principles. What I mean by that is working with families and recognizing that lots of parents, of course, understandably, are very stressed themselves. And many carers will have anxiety or depression. And there is also a recognized significant impact on siblings. So the question there is, how are we making sure we have time to talk to parents about their mental health and to siblings about what's going on in life? Sometimes parents will say things in the room and it makes me think, I wonder whose symptom this really is. He's just so worried all the time. He says he's terrible as everything. He just wants to die. Sometimes those are feelings that actually sit within the parent or the carer and are being expressed through the child. And these are things that maybe psychiatrists are more familiar with talking about. But there needs to be space to check in and understand what's really going on in the family. So within our draft psychosocial standards of care, I'm not going to read through all of this, but we're going to be advocating for a screening for neurodevelopmental disorders. We're going to be advocating for cognitive testing to be done for all children. But the bit I've highlighted here is that the North Star reviews should assess the child's understanding and to give appropriate psychoeducation, as well as looking for any evidence of mental illness. There should also be equitable access to CAMS, CAMS being child and adolescent mental health services, because many children with DMD will be referred to mental health services which aren't related to DMD, and that referral just gets rejected because they say, well, this is a brain illness, we don't know anything about this brain problem. Finally, I think I have 1 minute left. We need to have conversations with ourselves, and what I mean here is to check in on how we are feeling and coping. And I'm talking mostly to the doctors in the room here, because of course this is hugely upsetting and burdensome for families and children themselves. But what we're not good at in medicine is making the time to discuss between us the upsetting and challenging things. So I run a monthly psychosocial surgery remotely on Teams, where people from the North Star centres, the clinicians, can call in and talk to me about their work, not just to ask me clinical questions, but to say about how they're coping with it. And in the UK, we run Schwartz rounds, which originated in America. And these are spaces for healthcare professionals to talk about the experiences of delivering care. The idea being, if we can share our thoughts and feelings with one another, we will deliver a higher standard of care. There is a parent psychoeducation project going on in the UK, which is addressing the emotional behavioural difficulties of children, which is very exciting. And there are some other helpful training resources like We Can Talk online. I think anyone internationally can access that. It helps professionals to learn how to have difficult conversations with young people about mental health. And I think because well, there we go, I'm bang on time. So I'll stop sharing and see if there are any questions.
Thank you very much for your lecture. Do you have any question for the professor? Okay.
Yes, hello. We've seen this 24 sites in UK. So let's say we have in the audience family with child who was just diagnosed. Can we reach out to any of these sites to look for support? If in Poland diagnostic is not so well developed in Duchenne.
So can you reach out to support from the UK professionals for these conversations? Is that the question?
Yes.
Well, I think the first thing is that hopefully our guidelines will be published within the next year, which will go through the things that I have discussed. It's not part of the project to be giving support to countries outside of the UK, I'm afraid. But it's an interesting idea. And if there is some momentum across European countries to do more conversation between the sites, that would be a good thing. And perhaps in our space at the end of the day, when we're having that discussion, we could consider that.
Okay, thank you very much. Any questions? Okay, so I think that
Hi, you've mentioned that you will be introducing this standard of care, the recommendations for that, but are there any actions from the UK government to actually ensure funding that this is carried out, like as trainings or in any other form, like throughout the UK?
That's a good question. I think the hope would be if you have clear standards, then the way it works in the UK is that the individual sites and hospitals would then be able to argue for more resource. But I can't see a situation in which the NHS says we are now going to give £1 million to this project, but it does mean that individual clinicians can argue for more resource from budgets, from pots of money in hospitals.
okay. Okay, thank you very much. I can't see any hands more. So